Hey doc, here we have patient C. Melanson. Uh, Very interesting case. Starting off with diagnosis, we have a mild class 2 molar relationship. I would say almost end on end class 2 molars. I would say a definite class 2 canine relationship. As with class 2 situations, we tend to have overbites. Overbites present themselves in different ways. In this case, the patient has had super eruption of her anterior segment. Well, maybe not. I'm looking at the zenus of the canines and the relationship of the cervical margin of the central incisors. It looks like we just have some delayed passive eruption or delayed altered eruption on number 8, giving that appearance. Therefore, if the maxillary segment seems to be in place, we would expect to see a elevated curve of Spee or exaggerated curve of Spee with the anterior teeth super erupting. Why is this important? Well, we want to be able to fix towards where nature had intended. So if we're going to fix the deep bite, we're not going to necessarily want to intrude the upper teeth. We may decide to do some of that, but that's not necessarily the problem. Why does this patient have super eruption of the lower segment? Well, they were unopposed because the mandible was kicked backwards, thereby giving the lower teeth more room to run superiorly until they ran into either the tissue of the palate or the kind of the base of the cingulum of the upper anterior teeth. So ideally, to solve this, we would do one of two different things. Let's take a look at this view again. Under the initial setup, this is the patient's current state. If we want to close this space, we have two different ways of doing that. So let's just start with the upper. We can advance the posterior segment anteriorly. That would, in essence, make the class 2 relationship worse. Or we can take the anterior segment and push it distally, not changing the slightly class 2 molar relationship. Or we can do a combination of the two. Let's come back to it. If we then look at the lower, what will happen when we level the curve of Spee and get those teeth in slightly better arch form and a slightly more proclined appearance? Well, you can imagine that they will run into these teeth here, the anterior upper incisors. So if we then have to solve that, so we're kind of unraveling the onion. If we want to solve that problem, why not procline the anteriors? Well, that all kind of makes sense. So if we procline the anterior teeth, both the uppers and the lowers, retract or close this space here, we would in essence get the teeth in relation to each other in a much better spot. But what I don't know is how much of this class 2 molar relationship is a function of the jaw being distalized as a function of the teeth being trapped in the anterior. This patient is too young to notice if there's any pathway wear or lingual wear on the upper anteriors, which may suggest entrapment. That's not always the case, but if it was present, we would definitely know that part of the problem of the molars being in class 2 has to do with the mandible being in a distalized position versus a skeletal or dental problem. Obviously, Ceph tracings allow us to unravel this. We will be adopting that technology soon, but as of right now, we have to use some reasoning to figure this out. So what I would do here is plan on creating a interincisal relationship of the maxillary and mandibular incisors to 135 degrees. There's a range somewhere between 115 and 130 being the ideal relationship. The reason why we want to do that, one, it's better aesthetically. Two, it's better functionally. We call that shallowing the anterior guidance. Right now she has a very deep anterior guidance, also known as being trapped. But by doing that, what we are looking to see is, will the mandible relax down and forward, or relax forward, so that the molars are in a better relationship? Then we can answer the question, all right, how do we close that space? Although I think it's unlikely, it could be entirely possible that there's a dental class 3 molar relationship. I'm being very exaggerated in this. But if the mandible was so trapped that it then fell forward, we might want to then, after we've unraveled the anterior segment with the first round of trays, then close the space by bringing those back teeth forward. More likely, we're going to unravel this. We're going to see class 1 relationship of the molar, and then we're going to close the space by retracting the upper segment posteriorly to close that space. This reminds me of our patient Bruce that you just finished the aesthetics on. Bruce had parafunction on top of having this relationship. Why is that important? Well, parafunction means the muscles are being overworked, or they're often applying a lot of force to the teeth. As a result, the bone around the teeth tends to be a lot more dense, and as a result, the teeth are harder to move. So when I did the orthodontic phase on Bruce, we did not see as much resolution as I would have liked. Fortunately, he also needed crown lengthening, so we were able to solve some of the problems surgically and restoratively, and not just with orthodontics. This patient doesn't show signs of any parafunction. So if I'm going to take a look at the top of the teeth, I don't see any signs of attrition. I see chipping, but chipping is more a function of incoordination or maybe habit, and not parafunction. Parafunction, you would see more attrition, which is universal wear of the teeth on the edge to edge or posteriorly. So I'm going to assume that we can get quite a bit of resolution in the anterior segment of this patient. Again, this is an adult, younger adult, but adults tend to be more difficult in more advanced movements like this. So I would manage the expectations with this patient that seeing full resolution of her deep bite is unlikely without some sort of surgical intervention. Yes, minor surgical intervention here on number 8 is possible because of the delayed passive eruption. That's not necessarily going to solve the problem of the deep bite. But what we're more likely to see is probably 50% deep bite when we're done, just based on experience. As we align lower teeth and we tilt them forward, the gum tissue tends to recede. And there's a saying in orthodontics that you have relative intrusion of teeth when you procline them. And it's just because when you procline them, they tend to tilt or dump down, giving the appearance that they're intruded, when in fact the actual apex of the tooth might be at the same vertical dimension. With that said, we're going to try some intrusion here. So what's the best way to provide intrusion of the lower anterior teeth with Invisalign? Horizontal attachments on the posterior teeth, beveled towards the gingival. I would do 4 millimeters, and place them as superiorly as you can, but without them interfering with the occlusion. You can either do that or have the technician do it. So I think right about there would be an ideal spot. I would do 30 trays, essentially 30 trays to try to get as close to that 135 degree interincisal angle between the incisors, and as much leveling of the curve of spee as you can. I would tell the technician, please create a flattened curve of spee on the lower, or even a reverse curve of spee. When orthodontists use wires, they actually have a reverse curve of spee wire that they place in there. The wire is not where the teeth are going to end up. The wire is purely showing the forces on the teeth. And we can build that same system in clear aligners. We just have to portray that to the technician. I don't know if I said this already, but the wording here is a little bit advanced. Keep in mind that the technicians are they're from Costa Rica with very little education. They don't care, nor will they understand the rationale behind things. Try to be as clear as you can when you're describing what you want done. Use bullet points. I have found when I wrote in paragraph form that they tend to overlook things. They do one thing and then they go back to it and they skip over things, whereas bullet points seems to be easier for them to follow the directions. That's pretty much it. Maybe just a little comment about delayed passive eruption. Teeth always erupt actively through the bone first, and then, this is during pre-adolescence when these teeth are erupting. Then the tissue retreats backwards, or the teeth don't actually erupt any further. They appear to erupt more as the tissue recedes. Delayed or altered passive eruption is when you see something like this, where the gingiva needs to be retruded a little bit further. Keep in mind that the position of the mucogingival junction is an important consideration on whether you want to do that or you want to do an apically repositioning flap, an advanced perio technique that should be taken into consideration, because the last thing you want to do is create a situation where the tooth is sitting in mucosa and not gingiva. That's just not as periodontally stable long term. But the reason I bring this up here, the cells that are sitting inside the tissue are quote unquote dormant, and it's very possible that with orthodontic movement, the activation of the osteoclast and the osteoblast induce inflammation that can wake up the cells here. So the question often comes up, do I do the gingivectomy first or after? It doesn't matter, but it's more conservative if you wait. And the reason is it might happen on its own organically, saving the patient the cost of the gingivectomy. I wouldn't worry too much about doing bone sounding here to determine the biologic width apparatus. We can assume that that is tissue there. I would look at a radiograph and just make sure that the CEJs of the two teeth are lined up. If they are, you can make the assumption that that can be removed with a laser or an electrosurge without rebound. But there are situations where this tooth will erupt, and for whatever reason, the incisal edge of the tooth wears, and the bone and the CEJ of this tooth are actually incisally placed compared to the adjacent tooth. That's a situation where you need to do bone sounding and determine whether or not you can reduce tissue without doing bony reduction or crown lengthening. So, I'm not trying to overcomplicate this, but these are the things we need to think about in order to avoid patients' expectations not being met. As with any situation, it's always better to think first and rather than explain to the patient after something happens. So, ask for 30 trays, getting that interincisal angle. I wouldn't worry too much about this gap in the first set of trays. You want 100% of the force of the trays being expressed here using these teeth as your brace. These teeth being number 3 to number 6. If the trays are being asked to close that space, then you're going to get less expression or less resolution of the anterior segment. Maybe manage that expectation with the patient that in the first set of trays, that's not one of our treatment objectives. This is definitely a case for VPRO or even Propel. Propel is using the rat phenomenon where you induce inflammation in the area to help the teeth move more readily. But I would start with just the VPRO 3 times a day, 5 minutes, having the patient bite into the trays or bite into the VPRO as much as possible, helping to induce the seating of the trays, because the power ridges that are going to sit on the teeth that help to tilt the tooth backwards are going to have to be engaged in the proper spot. If the trays aren't seated, then you don't see axial tipping of the teeth like we would like. And lastly, I would ask for